Hello, everyone, and welcome to the ACP Problem Solving in Oncology webinar series. My name is Dr. Harriet Baker. I'm one of the ACP Trainee Committee and an SPR in Medical Oncology at Addenbrooke's Hospital in Cambridge. I'll be chairing this evening's session. I'm currently out of programme doing a PhD with the Department of Radiology, focusing on the role of novel radionuclides in oncology. This evening's webinar will provide you with an overview of Theranostics in oncology, which is a term that combines therapy and diagnostics. It involves using radioisotopes to image and therapeutically treat the cancerous lesions, offering a personalised approach to cancer treatment. I now have the pleasure of welcoming our speaker this evening, Luigi Aloj, Professor of Nuclear Medicine at the University of Cambridge, Department of Radiology, and Consultant Clinical Lead of the Nuclear Medicine Service at Addenbrooke's Hospital. His research interests involve the novel applications of radiolabeled pharmaceuticals for the study and treatment of cancer.
Thanks for the invitation, Harriet, and thanks for the introduction. So hopefully I'll give you tonight a bit of the nuclear medicine physician's view on how we've come about to this era of theranostics, which are very pertinent to oncology, and sort of my career has been built around this, really. I'm very interested in sort of development of new methods, as Harriet pointed out, and been closely following this for quite some time from my training days. So we're going to start with a bit of history. So the concept of theranostics is actually intrinsic to nuclear medicine. The idea that you can have a drug that can show you where disease is and act as a proper diagnostic, and then also be adapted to deliver radiation to cure cancer has been around for a long time. So the use of iodine-131 was actually started in the 1950s, and it was applied to thyroid cancer. So the image here that I show is a classical case of metastatic papillary thyroid carcinoma. The image is seen here on the left, and this is a patient who had diffuse lung metastases and was treated with 5.5 gigabecquerels of I-131. This was a patient I treated at my previous work, and then 10 months later, there was still some residual thyroglobulin. We gave another dose, and you can see that the amount of actual abnormal uptake and disease-related uptake was much reduced. So we had significantly reduced the burden of disease, and these patients actually can actually cure and have essentially a normal life expectancy after this in many cases, even though the cancer is so advanced when you see them. From that same era, the idea that you could use bisphosphonates to image bone metastases based on the fact that higher areas of higher bone turnover accumulate bisphosphonates was adapted in the 70s, I would say, with tracers that essentially were designed to give low-level radiation to bone metastases. For example, one of these drugs was samarium EDTMP, which is a bisphosphonate, and these worked okay. They did some palliation of bone pain, but weren't very effective in terms of actually getting any sort of objective responses in cancer. So I think the turning point for getting these applications in nuclear medicine sort of more into mainstream was when these randomized clinical trials started coming out. And I think the first approved drug, radionuclide-related approved drug of the modern era is radium chloride, also sold with the commercial name of Xofigo, which was studies in this Alsimca study, which was sponsored by Bayer in the late 2000s, and it was looking at the use of radium chloride. Radium is a mimic of calcium. It is an alpha emitter, and this was used to treat patients with castrate-resistant prostate cancer. And this was the first proper randomized study where it was where radium was compared to control, and this was conducted between 2008 and 2011. It did show this overall survival benefit in these patients, which ended up then in this drug being approved, and was approved in the EU in September 2013, at the same time in the US. And this image here on the left is a case from our series. We can show actually you could get some objective responses with radium. So it was the first example of something that was actually proven to be effective and came out to approval. So until that time, radionuclide therapy was sort of a niche area. So there was a lot of work that was going on, for example, with somatostatin receptor targeting for neuroendocrine tumors. So in the late 1980s, this small peptide, octreotide, which is a derivative of somatostatin, was developed. It was developed to treat carcinoid syndrome in neuroendocrine tumors. But then it was recognized that it could actually be used to do imaging of neuroendocrine tumors. It was first labeled with indium, so this compound drug known as Octreoscan was licensed in the early 1990s and used throughout Europe and the US to image patients with neuroendocrine tumors and identify areas of disease. This concept was then again extended to treatment. So yttrium-90 labeled agents were parts of small case series that were published in the 1990s. And you can see this patient, for example, with a lung lesion, highly avid for the somatostatin analog, was being treated with this agent. In the mid-2000s, then PET came on board. So the use of gallium labeled agents. Gallium is a positron emitter. And so this was actually a changing point for imaging of neuroendocrine tumors, because the sensitivity and the accuracy of this kind of imaging was much higher compared to the indium octreotide that was available sort of a decade before. Even though it was just a minor change, it was the same compound, but just the different isotope made a huge difference in terms of what you could see. So the idea that you could use an imaging agent and then this would double as a therapeutic agent has been around for a while, and we're just now coming to actually being able to use it in mainstream oncology. So the somatostatin receptor targeting approach was again proven in a randomized clinical trial. This was the NETR-1 study, which was actually fairly recent. It was conducted in the 2010s, and this was a phase 3 study that was used for registration, and it enrolled advanced progressive mid-gut somatostatin receptor expressing neuroendocrine tumors, and patients were selected based on Octreoscan, so the imaging with Octreoscan, and were given this lutetium labeled agent known as lutetium dotatate, which is essentially a derivative of octreotide. And these patients either had 4 cycles of these 7.4 gigabecquerels of the lutetium dotatate with standard of care octreotide, or the control arm received double the amount of octreotide and best supportive care. And this is a progression-free survival from this trial. And you can see that the treatment arm fared much better than control arm, with many, many months difference in progression-free survival. Objective responses were fairly low, in that only about 20% of patients actually had an objective response, which was a complete remission or a partial remission. But in most cases, there was significant stabilization of disease, which and a progression-free survival benefit. So the drug was found to be safe, and in 2017, lutetium dotatate was approved in Europe for grade 1 to mid-gut carcinoids, and that's still the approval that we have, and it's NHS funded at the moment. But just to give you an idea of how long it took at the time to approve these drugs, so octreotide was approved by the FDA in the late 80s. There was some initial imaging attempts in the 90s. Then these other analogs came on board, which could be labeled with metals. So yttrium, which was used for therapy, and gallium, which is used for PET. Lutetium, again, in 2003, was another therapeutic a derivative of this. And then the trials came out that brought to approval of the gallium labeled agent for imaging and the lutetium labeled agent for therapy. And since 2018, the funding for Lutathera, which is the commercial name for this agent, which is used for unresectable or metastatic GEP-NETs in adults. So this the somatostatin receptor concept introduces this radiometal paradigm. So the idea that you can have the starting compound, so a ligand that binds a specific biomarker present on disease, and this biomarker is your target. You have the ligand here represented in red, which would be the octreotide, and then you have some sort of linker which will house, which has a chelator, and this chelator will then can hold on to a radiometal, which makes this whole process of labeling very versatile, because you can put any radiometal in this chelator, because there's a lot of cross-reactivity between multiple metals. So you can use metals for imaging. So gallium-68, for example, is used for PET, very commonly used. Indium-111, as I showed you for Actria-scan, it's used for gamma camera imaging or SPECT-CT. But then you can virtually use the same compound and add yttrium-90 or lutetium-177. So these are beta emitters, and these can give radiation that is therapeutic. And this Lutathera, which is the lutetium version of dotatate, is the one that has approved for treatment. But there's a bunch of other compounds that have been tested or are currently under investigation. More recently, other more interesting metals are these alpha emitters, the ones that emit alpha radiation. And we'll talk a bit more about these later on in my talk. So this was the first sort of success story of the modern era in terms of a targeted agent looking at a biomarker, the approval of Lutathera for somatostatin receptor targeting. So obviously, neuroendocrine tumors are not one of the big problems in oncology, but prostate cancer is. There has been a lot of work around treating prostate cancer, and there's been significant progress in the last 40, 50 years in the survival and the management of these patients. But obviously, prostate cancer is still, the incidence is very high and is a continuous, there's continuous efforts in trying to improve the treatment and the efficacy of these. So one of the biomarkers that was looked at for this, and this was discovered actually a long time ago, and actually the nuclear medicine community has been after this for quite some time, is this PSMA. It's known as prostate-specific membrane antigen. It's not very prostate-specific, but is this biomarker that has physiological expression in the prostate and other organs, as shown here. In cancer, it's very overexpressed in cancer cells and also in neovascular endothelium. So other cancers such as kidney, salivary also have overexpression. Interestingly, this biomarker is the expression increases with Gleason grade. So the more aggressive the expression you get, the expression is maintained in hormone refractory cancer. So again, with the more aggressive forms of the disease, maintaining the high target expression. And the fact that this is a protein-bound enzyme, a membrane-bound enzyme, makes this, is hypothesized that this has a role actually on cancer growth. So this is similar to an enzyme that's present in the central nervous system that's known as glutamate carboxypeptidase 2, and this enzyme in the CNS actually regulates the glutamate levels. It is highly expressed in the membrane of prostate cancer cells and the other cells that are shown, and there were several small molecule inhibitors of this enzyme that were developed for use in CNS, but then were repurposed for imaging as agents. And this KUE, so it's urea glutamate lysine binding moiety, is actually a part that interacts with the active site of the enzyme, and so it creates actually a very high affinity bond, and given the high density of these enzymes on the cell surface, it provides very good high target to background. So in this diagram here, there's also shown the antibodies that have been utilized by the nuclear medicine community also to target PSMA. So this J591, which recognizes this extracellular domain, and this 7011 antibody that was used actually for a registered agent that the FDA approved in the 1990s to image PSMA. But actually the game changer here was using of these small molecules, and this were the sort of the image that you could get, you could see these very tiny lymph nodes with PSMA avidity, indicating they were um, um, sites of prostate cancer, which would you could image even lymph nodes that were well below the size criteria that are normally used for CT. So a game changer in the ability to image even sub-centimeter lesions of prostate cancer. So like all these things start as imaging agents, and this was registered through this trial in the late 2010s, where proper multi-center trial with multiple blinded readers and validation with either pathology or other methods to assess whether the findings were actually true positives or false positives. And it showed that you could actually, at very low levels of PSA, even below 0.5, in about 40% of cases, you could actually localize disease with confidence, which was an important thing in terms of patient management in identifying where the source of PSA was in biochemical recurrence. And so these trials show that this was an effective way to image the presence of disease, and brought the approval and licensing of multiple of these PSMA targeting agents. The one that was developed first and most utilized, at least at our centers, is gallium PSMA 11, which is now manufactured by different companies. So again, you can image with this, and then you can bring that concept to advanced disease. So the initial studies around targeting the PSMA, the prostate-specific memory antigen for therapy, came out in 2015, 2016. A lot of these sort of very small case series done at individual sites. So this is a gallium PET at baseline, a lutetium PSMA treatment, 2 cycles, and you can see these anecdotal cases where you can see significant reduction in the PSMA avid disease after 2 cycles of treatment. So again, this prompted industry interest, and a study known as the Visual trial was set up. This was sponsored by Novartis. It looked at metastatic castrate-resistant prostate cancer. Patients enrolled had to have had previous chemotherapy or had to have contraindications to chemotherapy and have PSMA avid disease based on PSMA imaging of some sort, which was mostly PET. And again, here in this series, it was shown that both progression-free and overall survival in the treatment arm were significantly longer compared to the control arm. And so the objective responses here, contrary to what happened for somatostatin, were actually higher. So there was 10% patients having complete response and about 40% patients having at least a partial response, a reduction by RECIST criteria of the size of lesions. And so this compound, known as PSMA 617, labeled with Pluvicto, with lutetium, and registered with the trade name Pluvicto, was approved in 2022 in Europe and the US. And it is funded in most European countries as a treatment for patients with castrate-resistant prostate cancer after the first line of chemotherapy. NICE does not provide funding for this as of today, but this is expected to be coming soon. So at the moment, it is only available through self-funding or by insurance in the UK. So the success of this approach prompted a number of other studies which were aimed at bringing sort of this PSMA targeted therapy earlier on in the treatment of these patients. So Novartis again has sponsored these 2 studies, which go by the name of PSMA-4 and PSMA Addition. One looking at taxane naive, so pre-chemotherapy in patients with prostate cancer at the time when a shift in androgen receptor pathway inhibitors was proposed, or looking at adding PSMA targeted therapy in patients with androgen deprivation therapy and RP. So these studies were carried out over the last 6 or 7 years, and both have completed recruitment, and for one, the final results are out already. So PSMA4, again, this was the trial, another phase 3. Patients who had not received chemotherapy and were progressing on a single ARPI were given lutetium PSMA 617 or a change of ARPI in the control arm. Patients who progressed then on the change of ARPI were offered to cross over. And the initial results were published last year in 2024. So progression-free survival was prolonged in the lutetium PSMA arm. But overall survival, you can see, was not significantly changed. But the quality of life scores in terms of pain and other indicators were significantly improved in the PSMA 617 group, so that the treatment arm compared to the control arm, which is also another benefit. So more recently, the final overall survival data came out. This was published in the Annals of Oncology this year. And again, confirming that overall survival was not statistically different between the treatment and control arm. But some of this probably was due to the fact that the crossover of patients from the second-line ARPI to the PSMA treatment probably confounded these results. It was confirmed that lutetium PSMA prolonged radiological progression-free survival and time to worsening of the quality of life and pain. So this could be an alternative treatment to change in the androgen receptor pathway inhibitor in patients with metastatic castrate-resistant prostate cancer who show progression. The grade 3 or higher toxicities in the two arms was comparable in this study. Obviously, since cost effectiveness is an issue, it's unclear whether this will be approved, but at least it's data showing that you can actually move this treatment earlier on in the course of treatment and provide some benefit to these patients. The other study that I was talking about, this PSMA addition trial, it was another randomized phase 3 in patients with hormone-sensitive prostate cancer. These are patients that were on ADT and ARPI, and the experimental arm was addition of the lutetium PSMA to the standard of care ADT plus ARPI versus the control, which was ADT and RP alone. Again, crossover was allowed on confirmation of progression by imaging. Again, here, the radiological progression-free survival, which was the primary endpoint of the study, was met. And this is data that was actually just recently released for the ESMO. And so there's a significant difference at the moment of the progression-free survival in the lutetium PSMA treatment arm. There are so far no difference in the quality of life and pain scores. There is a positive trend over overall survival, but the data is not mature enough, and so we require a few more years to get that data collected. What has come out of these trials is that no new sort of longer-term safety concerns or safety concerns when the treatment is associated with other treatment. So that's also a positive in terms of the side effect. And so recruitment for the study is complete, and there will be more coming out in coming years on the use of these approaches and the results of this trial. But going back to the possible targets, so some of the targets that are really of interest are these, have to be membrane bound and highly overexpressed in cancer cells. So there's a plethora of these membrane-associated proteins, for example, G protein-coupled receptors that have been looked at and studied over the years and have gone through an extensive phase of preclinical and sort of in vitro development, and now we're coming to clinical trials. So just to reiterate, we can use different nuclides as labels for these compounds. So depending on what we want to do, we can image with SPECT. So we have gamma emitters or positron emitters, and then we have beta emitters or alpha emitters for therapy. And we can use these labels to couple to these ligands, which we can do with different methods. And the drugs that we use then to target our specific biomarkers are either antibodies, peptides, or small molecules or metabolic substrates. And these then interact with our target. And these targets are receptors, antigens, or any other sort of biomolecule that is relevant to the cancer and overexpressed in the cancer relative to the surrounding normal tissues. And we can use this to detect, characterize, quantify, and deliver radiation. And just to get an idea of how rapidly the field is progressing, this is a review we published a few years ago. It was looking at the trials that were using imaging to guide therapy. And most of the activity at the time was around somatostatin and PSMA, and there was a few studies here on these G protein coupled receptors that are of interest. So this was 2021, so this was probably a table from 2020. This is the map of what is happening now in terms of industry and how this is expanding. So these are all the different companies with different ligands that are being tested. This outer circle here looks at the preclinical drugs in development. And as you go into the circle, you get later and later into clinical phases. The two compounds at the center are the Lutathera, the somatostatin targeting agent, and the Pluvicto, which is the PSMA agent, which were approved. But all these companies are doing these phase 1, 2, and phase 3 studies to try to get these compounds in the clinic. And so these are the main ligands that are in development. FAPI is a target of particular interest that's come out in recent years. GRP bombesin is another target that we have also worked on here in Cambridge, and several other of these specific cancer targets. So the market value of Theranostics is currently around 4 billion and is projected to get to around 13 billion by 2029. So there's a lot of investment and expectation that this will be implemented in not just these initial indications. And just to get an idea of how pharma's interest is in this, there have been significant buyouts of small biotechs that have developed these ligands. So Bristol Myers Squibb acquired this company called Raise Bio, which is developing some alpha emitter agents for somatostatin expressing neuroendocrine tumors. AZ has bought Fusion, which is a Canadian company that has developed antibody strategies to target some of these agents. And Eli Lilly has purchased Point, who have a DLL3 asset, and Mariana is in the immune checkpoint inhibitor business, and so looking at those as targets for radiotheranostics. So some of the things that we should be looking forward to, these are some studies that are very preliminary and again, small case series, which will probably drive development of larger studies. The use of alpha decay. So this is alpha decays are these very large particles that have very high linear energy transfer. And so if you can deliver these isotopes very close to the target, it actually creates massive ionizations in a small volume and can be much more effective than currently used beta emitters. And there's several examples in the literature of alpha emitters that have been used with the somatostatin receptor targeting approach, showing very good objective responses, which is something that we don't see typically in the lutetium type studies that that have approved the use of Lutathera. So this is actinium, which is it's probably one of the most utilized at the moment in these clinical trials, but also bismuth, which is a short-lived alpha emitter, and lead-212 have been utilized and show very promising initial results, and will probably be the focus of most of the upcoming trials in this space. Of the targets, the FAPI I mentioned earlier, it's a fibroblast activator protein. which is a protein that's overexpressed in cancer-associated fibroblasts, has been shown by imaging to be a very sensitive detector of areas of disease. And you can see these are images on the right of multiple different cancers, which can actually be targeted and localized using FAP inhibitors with gallium-68 with PET. And there's a lot of work going on in this area to develop adequate therapeutics based on FAP. So to summarize, the drive for theranostics has come from the increasing knowledge of molecular biology of cancer and identifying these new targets. There's been a lot of work in developing radiochemistry, and that's part of my work in looking at how to develop new ways of labeling molecules and studying molecules. Advances in the availability of different radionuclides, so producing these radionuclides through reactors and cyclotrons and the like. Expanding access to PET-CT and SPECT-CT has also improved the access to this technology. And obviously, the interest of big pharma now makes this an area that's going to expand significantly in coming years. So at the moment, we still have few approved indications for a very limited spectrum of diseases, but the trial activity and the potential of this to actually impact areas of unmet clinical need is very exciting. And the future exploring new targets. So the work that we do here, sort of developing and finding new things, is an area which is very exciting to explore. The expanding access to alpha emitters, I think, will be key in determining improved efficacy of these agents. And of course, all the studies that we've talked about now, these are all single agent type trials. And we haven't even touched the surface about what we can do with combination treatments with are obviously things that are more in the remit of this audience in terms of things to explore for the future. So what is the path going forward? There will be an expanding role, I anticipate, for these type of applications in mainstream oncology. A lot of investment and expectation by industry. It will have a lot of opportunity and challenges, but it will, I think, bring closer the nuclear medicine community to the oncology community in designing and developing these treatments. And that's something that I think we're actually growing here and doing a lot with these interactions with our oncology colleagues. And just to plug, we have some clinical research training opportunities here in Cambridge. If anybody is interested, we have some work that will be focusing on these areas of interest that I just discussed. And so if you want to have a look and get in touch with us if you're interested. And that concludes my talk, Harriet.
But thank you so much, Gigi, again. And yes, have a good evening, everyone.
All right. Well, thanks for the attention. And yeah, I mean, I'm happy to get in touch if anybody wants to discuss and you're interested in any of this. I mean, there's a lot of opportunities here if you want to come and do some work with us. And you know, there's also other opportunities at other places in the country. At the moment, this is still sort of confined to sort of larger centers, but this is something that's going to be, I think, changing in coming years. So if you're interested, this is something I think the oncology community will be very involved in going forward. And so I think it is relevant. It will be relevant to your careers.